So what we're going to be doing is checking our patient's OAA joint by doing flexion and extension. So what I'm gonna have my patient do is we're gonna start with flexion first. So I'm gonna have her first tuck her chin down, good, and then I want you to just look down at the floor, good. And what we're looking for here is if our patient felt any limitation, or if they felt any of their symptoms or headaches happening, then that may implicate the upper cervical spine. For our extension, what I'm going to have our patient do is look straight ahead for me, and then can you jet your chin out like this? So I want her to get into a forward head posture here, and then can you look up into the sky? Good. So we're getting some extension here as well. And the same thing, so if she had any of her complaints of pain or a headache, then that would implicate the upper cervical spine. So the next test that I'll be doing is the cervical flexion rotation test. And so this is checking the AA joint, so the upper cervical joint of the spine. So what I'm going to be doing with my patient is, can you scoot back just a little bit more? Okay. I'm going to be placing my hands on her head. Okay, so I'm just gonna put my hand right on your forehead, and I'm gonna bring her into a little bit of flexion, and then I'm going to turn her head. And what I'm looking for here is symmetry on either side. So I'm gonna turn to the right side, because you should have about 45 degrees of rotation. You can relax. You should have 45 degrees of rotation and should be symmetrical on either side. If she were to have a 10-degree difference between both sides, and that may indicate that there's an issue at that joint. People with cervicogenic headaches also tend to have an issue with that joint as well. So that's the test. So next we're going to be talking about the patterns for mouth opening. So normally when a patient is opening their mouth, they should first start, in the beginning, posterior roll of the condyle. As she continues to open her mouth, she starts to have an anterior glide of the condyle, and then for those last couple of meters, we go back into a posterior roll. Okay, so that's with the mouth opening, and then mouth closing would just be the opposite of that. Sometimes if patients have muscle spasm or any issues with their disc in the TMJ joint, this does not happen. So if she were to have any muscle imbalances or muscle spasm or anything where the muscles of mastication weren't syncing up or firing correctly, then she may demonstrate an S sign, which is when she starts to open her mouth and it's going down and then it makes an S. So it kind of goes to one side, the other side, and then back to the original side. And that I would just watch her mouth to see what would happen in that case. Yep. And then, so that would indicate some issues with the muscles of mastication. That would also be called deflection. So S sign would be deflection. For the C sign, that may indicate a capsular issue or just an issue in the joint, so an interjoint issue. For the C sign, which is also known as lateral deviation, what I'm going to have my patient do is open her mouth, and I'm just looking to see when exactly it deviates. So if she were to open her mouth and it starts to deviate early, that would indicate hypomobility of the ipsilateral side. So that means on the left side, she has hypomobility of the TMJ joint. Let's say she were to open her mouth and I didn't see any deviation until the very bottom part. That would indicate hypermobility. So it would indicate hypermobility of the contralateral joint. So since she's deviating to the left side, it would be hypermobility of the right side joint. So the next test that we're going to be doing are our resisted isometrics of the neck muscles. We're going to start with flexion. So what I'm going to have my patient do is, I don't want her to be in neutral, I want her to be in slight flexion. So can you just look down just a little bit for me? Good. Okay, and I'm going to be placing the palm of my hand on her forehead. So I'm just going to put it like that, and I'm just going to have her push against my hand. So push. Good. And now relax. And now what I'm going to do is we're going to test extension. So I'm going to have my hand on her chest and one hand on the back of her head. So can you push against my hand? Push, push, push. Okay. Next, what we're going to be doing is side bending. So I'm just going to have her, we're going to start on this side. Can you try to touch your ear to your shoulder on this side? So push. Good. And we're going to do the same thing on this side. So push on this side. Good. Okay. And then the last thing that we're going to do is rotation. So I'm going to have my hands on the sides of her head. And I just want you, can you rotate your head to your left for me? Rotate it. Good. And then we're going to do the same thing on this other side. So rotate to the right for me. Good. Okay. So if she had any of her symptoms or any complaints of pain, then we implicate certain muscles with those different resisted isometrics. And I would also do the motion that was painful at the end. So if rotation was the painful thing for her, then I would leave that for the end of the isometric strength testing. For the myotome testing, I would have done flexion, rotation, and side bending to test the C1, C2, and C3. C1 is for flexion, C2 is for rotation, and C3 is for side bending. And the difference that I would do, instead of just holding it for a little bit, I would actually have her hold that contraction for 10 seconds to see if it were to weaken within that time. The next myotome that I'll be testing is C4, which is the shoulder shrug. So I'm going to be standing back here just for the sake of the video, but I would normally stand in front of the patient. So would you bring your shoulders up? Good. Don't let me push you down. Good. Again, holding it for 10-second increments to see if she gets tired after that amount of time. The next myotome we'll be testing is C5, which actually has two different tests for it. You can either do external rotation of the shoulder or shoulder abduction. So this is just good to have options just in case the patient isn't able to do shoulder abduction without pain, then we can also always do external rotation or something like that. So would you be able to lift your arms up? Good. Don't let me push you down. Same thing on this side. Don't let me push you down. Okay, and for external rotation, can you have your arms out like this? Don't let me push you in on this side. And then the same thing on this other side. Don't let me push you in. Okay. So the next myotome that I'll be testing is C6. There are three options that we can choose from, either elbow flexion, wrist extension, or shoulder internal rotation. So we'll start with elbow flexion. So can you bend your arms? Good. Don't let me push you down. Again, my positioning would be better if I was actually doing the test, but just for the sake of the video, I'm going to be doing it off to the side. Okay, next one that we'll do, can you bring your arms like this and then bring them in? Okay, bring them back out. All right, don't let me pull you out. Same thing on this side. Don't let me pull you out. For the last one, the wrist extension, can you have your hands out like this and then bring your wrists up? Good. Don't let me push you down. Same thing, don't let me push you down. Okay. The next myotome we'll be testing is C7, so that is triceps and wrist flexion, or elbow extension and wrist flexion. So can you bring your arm over your head, and then don't let me push you down. We're gonna go on the other side and do the same thing. Don't let me push you down. And then for wrist flexion, I'm going to have her flip her hands over and then bring your wrists up. Don't let me push you down. Don't let me push you down. So I am going to be testing the C8 and T1 myotome. So for C8, what I'm going to have my patient do is, can you hold your hand up like this? Good, and you can put your finger up like this. And then I'm just gonna push, I'm gonna stabilize at the wrist and push down. So push against me. And then I would do the other side. The next one that I'll be testing is T1, which is for the inner hand intrinsics. So I'm gonna have my patient hold her hands out, and I'll be standing here. For the sake of the video, I'm just gonna do one hand. I'm gonna place my fingers in between, and then I'm going to try to push out against her. Try pulling. Oh, okay. Can you push against me? Push in. Good. Okay. And then for abduction, all right, push out against me. Push out. So testing adduction and abduction of the fingers. Okay. Next test I'll be performing is a craniocervical flexion test. So we're going to start with our patient in supine and with her legs in the hook lying position, so just with her knees bent. And I have a towel underneath her head just in case her neck was not in neutral. So you don't have to have the towel, it just depends on whether or not her head is in neutral. I also have a cuff underneath, an inflatable cuff underneath her neck. And it's not a stabilizer cuff, but for the sake of the video, it's just like a normal cuff, like blood pressure cuff. So what we would do is we would start with the cuff deflated, and then we would inflate it to about 20 millimeters of pressure, and then have the patient nod so you can tuck your chin. So this nod should move the pressure up to 22 millimeters of pressure, and she should hold that for 10 seconds. And you can relax. So if she and while she's holding it for 10 seconds, I shouldn't see any of her superficial muscles working. So SCM, I shouldn't see start to kick in. And she shouldn't just push the whole head back. She should just be holding her chin in a chin nod like this, and then relax. After that, I would have her perform that chin nod again until it went up to 24 millimeters of pressure, in which case I'd have her hold it again for 10 seconds. And then you would just keep going up by increments of 2. So it would be normal for the patient to get to at least 26 millimeters of mercury for a 10-second hold without any compensation. Next test I'll be performing is the deep flexor endurance test. And then can you tuck your chin for me? So she's gonna retract her neck, tuck her chin, and I'm just gonna lift her head about an inch off the table. And now I want you to hold this position. So I'm gonna let go of her, but I'm gonna keep my hands underneath. And so what I'm looking for is that she holds this position without any compensation of the superficial neck muscles or SCM. Okay, and you can relax here.
If I notice a loss of chin tuck, or if the patient's head touched my hands, the test would be terminated. According to the McGee text, people with neck pain average at about 24 seconds for this test.
So next we'll be doing the muscle length tests. The first muscle length test that we'll be doing are for the upper traps. So what you want to do is flex the patient's head, side bend away from the side that you're testing. So if I'm doing the left side, then I would side bend to the right, and then I would rotate toward the tested side. So again, if I'm testing the left side, I would flex the head, side bend to the right side, and then rotate the head towards the left side. So you can also set up the table so that it is already flexing the head, so then all you have to worry about is side bending and rotating. I'm gonna try to use my forearm for this instead. So I'm gonna have the patient's head. I'm just gonna put my hand right here, or my arms, and you can just relax. So again, I'm also going to depress the scapula. So I'm depressing the scapula, and then she's already in a little bit of flexion, so now I'm gonna side bend towards the right side, and then I'm going to start to rotate towards the left. And then I'm just looking for her complaints of pain, or I'm comparing to, I'll just relax your head. I'm gonna compare to her uninvolved side and see if I get less length on that side, and that would be a positive sign for this test. The next muscle length test that we'll be doing is for levator scapulae. So what I will do with my patient is, again, I'm going to have her head flex, which you can do with the table. I'm going to be depressing her scapula, and this time I'm going to side bend and rotate away from the tested side. So if I were testing her left side, then I would rotate and side bend to her right. So again, I'm just gonna lift your head up, So we'll start by, start by bringing her into a little bit of flexion, and then I'm going to depress her scapula. And so now I'm going to side bend and rotate towards that side. So now we are testing levator scap. And again, we're looking for the same thing. So either the patient's complaints of pain, or we're comparing to her other side and seeing if we have more tension on the involved side than on the uninvolved side. So the next muscle that we'll be testing is sternocleidomastoid. So what we're going to want to do for this one is have the patient's head off the table so that we can get her into extension. For this one, we are going to side bend away from the side that we're testing, and then we are going to rotate toward that tested side. So again, I'm going to have my forearm underneath, but I'm going to let her extend just a little bit. If I'm testing the left side, then I'm going to side bend to the right, and then I'm going to turn her head toward that side. Okay, and to get more of a stretch here, you can place your hand on her chest and depress the sternum so that we get a bit more of a stretch on that side. And again, we are just looking for our patient's complaint of pain, and we're comparing it to the uninvolved side, or the involved, I'm comparing it to the uninvolved side just to see if there's a difference in length between the two. So the next muscle length test that we'll be doing is for the scalenes. For the scalenes, we'll actually be having the patient do these on herself just so that she can kind of gauge better for how much of a stretch that she needs, and just in case we wouldn't want to put too much tension on the scalenes and cause any pain going down her arm. So we are going to be testing the anterior, middle, and posterior scalene. And what we're looking for is either asymmetry when compared to the uninvolved side. We are also looking for her willingness to move, so whether or not, how far she's willing to move her head to stretch the scalenes, and whether or not that causes her complaints of pain as well. So what I'll have a patient do if we're doing the middle scalene is, can you reach your arm over to that ear? Yeah, just touching your ear. And all she's gonna do is pull her ear down. She's pulling it down to her right side and looking for a stretch here. To increase the stretch, she can bring her arm off to the side and pull down on the chair. So now she's pulling down on the chair and getting even more of a stretch in this area. For the posterior scalene, what we're going to have her do is she is going to be in somewhat of the same position. Her arm is still going to be on this side. She is still going to be side bending, except now she's going to be rotating toward and down and looking toward her armpit. So pull off to the side and kind of rotate down like you're looking down. Good. And the same thing, she can also have her arm off to the side, pulling down so she gets more of a stretch of that posterior scalene. For the anterior scalene, we'll be doing something similar, except now she's going to bring her arm behind her back. She's going to have her arm overhead just like that, but now she's going to pull off to the side and then rotate her head and look up towards the ceiling. And that is how we are going to stretch the anterior scalene. Next, I'll be performing two different distraction techniques, just looking at the ligament laxity in my patient. So the first one that I'll be doing is a technique to specifically look at C1, C2. So what I'm going to do is start with my patient in supine, and you can actually scoot down just a little bit. Okay, and I'm going to take one hand. Well, first I'm going to feel for the C2 spinous process. So once I found that, I'm going to bring one hand around C2 to help stabilize. And then I'm going to bring my other hand underneath the occiput. And then once I'm stabilizing C2, I'm going to bring my shoulder and place it on her forehead to kind of help tuck the chin. And then I'm going to move back. So I'm getting that distraction from C1, C2. The next type of distraction that I'm going to do is a general distraction, which I can do supine. So I would just bring my hands underneath the occiput. Okay. And I would pull back. I could also do this seated. So Jasmine, can you sit up and just face that way? Past yeah. So from here, I'm going to lower my table. So for this general distraction, I'm going to have both my hands. I'm going to place them underneath her occiput here, and then I'm going to kind of leverage on her shoulders and push up. So again, while performing that distraction, I'm just feeling for any instability there. So if I felt any clunking or things like that, then that would be a positive sign for this distraction. Next test that we're going to be doing is testing for ligamentous instability in the cervical spine, and it is called the anterior shear test. So what I'm going to have my patient do is start in supine. What we're going to start by doing is we want to find the posterior arch of C1 with the lateral part of our fingers. So I'm going to start by going underneath her head. I'm going to go underneath the occiput. I can look for the spinous process of C2 and just come up so that I'm at that level. So I'm resting off the posterior arch of C1, and I'm looking to lift the patient's head towards the ceiling, and I'm looking for any clunking or any of the reproduction of the patient's symptoms. And that would indicate an upper cervical ligamentous instability. If she also was having any nystagmus or diplopia or dizziness, things like that, then that would also implicate the ligamentous. The next test that I'll be performing is the C-spine sharp pursor test. This is specifically testing the transverse ligament. And so what we're going to be doing is we're going to be finding the spinous process of C2. So coming down to the most prominent bone right under the occiput. And then I'm going to pinch that with my fingers. So I'm going to stabilize the spinous process of C2, and with the other hand, I'm going to use my web space and place it on her forehead. So hopefully you can see that. So from here, I'm going to be providing a posterior force backwards. Now what we're going to do is I'm going to have my patient actually start to tilt her chin down and look down. And what I'm looking for is kind of like a clunk. And that may be a relocation of the dens, or we're looking for a reproduction of symptoms, or any like nystagmus or dizziness or things like that while she's performing that downward motion and while I'm providing that posterior force. So the next test I'll be doing is testing the alar ligaments, and it is called the lateral flexion or side bending stress test. So what we're going to start by doing is, I'm going to put your hair in front, is finding the spinous process of C2. And once I've found that, I'm going to stabilize it with my right hand. And then from there, I'm going to hold the patient's head, and I'm going to bring it to the side. So I'm going to side bend it, and I should feel the C2 spinous process pop into my hand. So while I'm bringing her head down to the left, I should feel her spinous process pop into the right side, pop into my hand. So then same thing, I'm going to move to the left, and I should feel it immediately pop into my hand. So again, now she's moving, side bending to the right, I should feel the spinous process move into the left side. And that should happen pretty quickly. So if I felt any excessive movement at the occiput, or a failure of the C2 spinous process to move, or any reproduction of symptoms, then that would be a positive sign for this test. Also, any of the 5Ds as well. So I'm going to be performing another alar ligament stress test but this is a rotational stress test. So I'm just gonna move my patient's hair out of the way. So sorry. Okay. So first what I'm gonna do is the same as the last stress test. I'm going to palpate for C2. And once I've found C2, I'm gonna stabilize with my other hand. And I'm actually gonna use this hand so you can see better. And I'm gonna place my hand on top of my patient's head. And instead of side bending, I'm actually going to rotate the head. So I'm going to rotate my head to the right. As I rotate the head to the right, the spinous process of C2 should go into my index finger on this side. And then as I rotate to the left, the spinous process should rotate into my thumb on the right side. So a positive sign for this test would be if there was a big difference in direction when you rotated. So if it rotated more than about 30 degrees, then it would be considered a positive test. Also, if you got a clunk, then that would also be a sign of a positive test on the side that you're rotating to. The next test that I'll be doing is the AA transverse shear test. So what I'm going to do is I'm going to get this part of my finger and I'm going to use it to stabilize the C2 at its transverse process. And then with my other hand and that other side of the finger, I'm going to the transverse process of C1. And while I'm stabilizing C2, I'm going to push C1. So creating, so kind of like this. So I'm creating a shear force by pushing on C1. So a positive sign for this test would be if I've found any clunking, if the patient complained about her symptoms, or any of the 5Gs as well, so any nystagmus, double vision, things like that. That I'll be performing is the brachial plexus compression test. So for this test, we'll have our patient in sitting, and what we're going to do is we are going to palpate for SCM and our upper trap as well. So first we're going to start by palpating, and then once we find that spot, you're going to go to just above like the clavicle, and what you're trying to do is compress the brachial plexus. So when I compress the brachial plexus, I'll ask my patient, and I'll also compare to our uninvolved side, whether or not, what symptoms she's feeling, if she has any. So if she starts to complain about her reproduction of symptoms, any paresthesia or pain going down the arm, when you do that compression, then that would be a positive sign for this test. So for the distraction test, I'm going to be placing my hands underneath, like by her occiput. And then I'm just going to tell her that you can kind of rest into me and just relax. So now she's kind of up against me. And then I'm going to provide a distraction of her occiput. And this causes distraction all the way down her cervical spine. And I would hold this for about 30 seconds. And what I'm actually looking for by doing this is relief in her symptoms. Now, after I held that for 30 seconds, I would have to be careful when I'm letting go of the pressure and just kind of slowly release after I've done that distraction, because you don't want to kind of just abruptly stop and just let your arms down. The next test I'll be performing is the Sperling's compression test. So what I'm going to do is, the idea is that you want them to side bend away towards the side that you are not testing. And you would have to compare each side too. So you do the uninvolved and the involved side. So first what we're going to start with is her neck in neutral. And I'm just going to have her, let's say I'm testing the left side, I'm going to have her tilt her head and side bend to the right. And then I'm going to provide some compression through her head while she's side bending. And then I would do the other side as well. Same thing. Let's say that didn't reproduce her symptoms, then I would have her do a little bit of flexion in the neck. So just look down just a little bit, and I would do the same thing. So I would provide compression on one side, And then after she side bended, so when she side bended to the right, then I'd add the compression. And then the same thing, when she side bended to the left, I would provide that compression. And the last one that I would do, if that still didn't reproduce her symptoms, I would go into extension and then side bend again and provide that same amount of compression. So a positive sign for this test would be the reproduction of the patient's symptoms. The next test I'll be performing is the Jackson's compression test. For this test, it's similar to Sperling's, except what we're going to be doing is rotation rather than side bending. So I'll have my patient rotate her head to the right. Good. And then that's us testing her left side. And then I would provide that compression. So I'm providing that compression. And then I would have her go and turn to the left. And then the same thing, supply compression. And a positive sign for this test would be a reproduction of the patient's symptoms while I was adding that compression in. The next test that we'll be performing is the shoulder abduction relief test. So this is a test that we wouldn't necessarily do on our patients. We would actually just be listening to our patients, and they may mention that the only time they have relief from their pain is when they lift their hand up and put it above their head. And sometimes they may sleep like that too. But if we did want to attempt to reproduce this test, then we would have our patient, okay, can you bring your arm and can you put it up on your head? And we would see whether or not that would relieve her symptoms down that arm, and we would compare both sides as well. So the next test that I'll be doing is an upper limb tension test for the median nerve. So this is one of the ways that we can differentiate between a nerve root problem and a peripheral nerve problem. So for the median nerve, I'll have my patient in supine. What I'm going to do, can you actually scoot towards me a little bit more? Awesome, okay. I'm gonna hold her hand here and keep it in some flexion, and I'm gonna bring her arm, well first I'm gonna depress her scapula, then I'm gonna bring her shoulder into abduction, about 90 degrees. From here, I'm going to supinate the hand and externally rotate at the shoulder, and I'm gonna extend the fingers and the wrist. So from here, I'm going to slowly start to extend the arm. This is the last thing I do, and I'm looking out for her. Are you feeling any of your symptoms? Mm-hmm. Okay, so I would stop there. Let's say that she wasn't feeling her symptoms at that point, then I would keep it at that length, and then I would ask her to side bend. So can you like touch your right ear to your right shoulder? Good. And then I would look to see if she was having any of her symptoms then. Just relax. And you would want to compare it to both sides, because sometimes a patient can have like a normal, some like tingling at the end of her fingers, but that's not necessarily abnormal. So again, just comparing the uninvolved side and the involved side. The next upper limb tension test that I'll be performing is for the radial nerve. So what I can start off, what I could have my patient do first is, can you cover your thumb with your fingers? So she's already kind of made a fist here. And from here, what I'm going to do is I'm going to, again, depress the shoulder, and then I'm going to start to abduct. But I don't have to abduct the shoulder as much as I did for the median nerve. From here, I'm going to pronate the wrist, and then I'm going to, pronate the wrist, and then I'm going to flex the wrist, and I'm going to keep that fist closed. And then I will start to extend again. And again, I'm waiting, I'm asking her, like, okay, are you feeling any of your symptoms?
Not yet.
Okay, so if she's not feeling any of her symptoms at this point, well, I'm still, you can't really see it, but I'm keeping her wrists and her fingers flexed. Then I would have her side bend away from the shoulder just to see if that brought on her symptoms. Okay. And again, checking the uninvolved side as well. The last upper limb tension test that I'll be performing is for the ulnar nerve. So for this test, again, we're going to start by depressing the shoulder blade. I can have her hand open though too, and I might grab it just a little bit just to help me. So I'm going to depress her shoulder here. I'm going to bring it into a little bit of abduction, and from here, I'm going to bring her hand so that it touches her ear, just like this. So still kind of still extending at the wrist and extending at the fingers. And again, asking her, like, are you feeling any of your symptoms? So if she was, sorry, let up just a little bit, let's say that she wasn't feeling any of her symptoms though, then I would side bend again her head away from the side that I was testing. The next test that I'll be performing is the Lamette signs test. This is a test for a cervical myelopathy. If a positive sign for this test would be a reproduction of a sharp electric pain going down the side that we are testing. So that'd be a positive sign for a myelopathy. This is similar to the slum test. So I will start with my patient in long sitting position. Next, I'm going to just have her bend her head, so bend her neck like this, and I'll kind of hold that. And then from here, I'm performing a passive straight leg raise. So I'd be holding up her leg, like so. And then I would ask her, are you feeling any of your symptoms? Okay, and if she was, then that would be a positive sign for this test. I'll show it on the other side too, just so that you can see, because we like to compare both sides. So again, having her tuck her chin, bend her neck, and then lifting her leg on this side, so performing that straight leg raise. Okay. The next test that I'll be performing is called the Hautant's test. I'm sorry if I mispronounced that. This is a test for any vascular issues in the upper arms. So how I would perform this test, that I have my patient sitting, and then I would have her hold her arms out like this, palms facing up. From here, I would have her just close her eyes and hold this position for 10 to 30 seconds. If within that time, one of the arms lowered, that would indicate that this was a non-vascular issue. You can open your eyes and put your arms down. So if one of her arms fell while she was doing that, again, that'd be a positive sign for a non-vascular issue. The other way to do this test is if I had her, again, still sitting, and I'm still gonna have her arms out in front of her like so, but instead of closing her eyes in this position now, I'm gonna have her look towards me. So now she's extending, rotating the head and side bending just a little bit towards me. She can keep her eyes open, but again, keeping her arms in front of her 10 to 30 seconds. So if one of her arms lowered again, that would be a positive sign for this test, and that would indicate a vascular issue. The next test I'll be performing is the vertebral artery quadrant test. This is a test that you would want to perform before any manipulation of the cervical spine, just to see if we had any issues with the vertebral arteries. So this is a big test to do before doing any sort of manipulation in the spine. So I'm going to have my patient, can you come towards me? Again, I'm going to support her head, but we are going to put her into some extension, and then, we're going to side bend and then rotate. And from here, I'm actually just looking at what her eyes do. So I'm looking to see if there's any of the 5 Ds.
Dizziness, diplopia, dysarthria, dysphagia, or drop attacks.
So I would do that on one side, and then I would also do it on the other just to compare, just to see if we get any of the 5 Ds. If I were to get any of the 5 Ds, then that would be a big no-no for any manipulation or anything like that. This is kind of similar to a pre-manip hold that you want to do before any manipulation, just to see if they have an adverse reaction to it. Okay. The next test I'll be performing is checking my patient's first rib mobility. So I'm going to come posterior to the clavicle to feel for the first rib. And all I'm feeling for is whether or not there's asymmetry between either side, so both my fingers on either side of the first rib. I'll ask my patient if she can breathe in for me really deep, and I should feel it evenly come underneath my hands. And then after that, I'll have her side bend to the left, so you can side bend to the left, and her first rib should pop into my right finger. And then when she side bends to the right, her first rib should pop into my left finger. The next test I'll be performing is the Adson's vascular test, and this is checking for thoracic outlet syndrome. So what I'm going to have my patient do is she's going to be sitting. I'm going to have her give me her arm, and I would check either side, like both sides as well, just to see what would happen. And I'm finding her radial pulse. From here, I'm going to, once I found her pulse, I'm just going to externally rotate the arm, and I'm going to ask her to look down towards her arm, like over here. And then from here, I'm going to ask her to take a deep breath and hold it. So you can take your deep breath and hold. And if I feel her radial pulse diminish at any point, then that would be a positive sign for this test. The next test I'll be performing is the costoclavicular test, again checking for thoracic outlet syndrome. This is similar to Adson's vascular test, except that we're not going to have any rotation of the neck during the test. So again, I'll have my patient give me her arm, and I'll feel for her radial pulse. From here, I'm going to bring her arm into extension, external rotation, and abduction. If once I abduct, I don't feel her pulse anymore, then that would be a positive sign for this test. The next test I'll be performing is the Ruse test. This is a test for thoracic outlet syndrome, specifically for any neurological involvement in thoracic outlet syndrome. So what I'm going to have my patient do is I'm going to ask her to lift her arms up to about 90 degrees on either side, good, and then you can open and close your fist. So she would perform this for about 3 minutes, and if she had any numbness or tingling or any of that kind of neurological signs in her fingers or hands, that would be a positive sign for this test. So if she did have any blanching of the hands or loss of temperature in the hands, then that may be more indicative of a vascular complaint for thoracic outlet syndrome. The next test I'll be performing is the Wright test, which is a test for thoracic outlet syndrome. So what I'll have my patient do is, can you scoot back for me a little bit more? I'm standing back here just for the purposes of the test, and so that you can see what I'm doing clearly. But I'm going to feel for her radial pulse. Then I'm going to externally rotate her and abduct her shoulder up to about 180 degrees. And from here, I'm feeling if her radial pulse is diminished at all. If it were to be diminished, you can relax, then that would be a positive sign for this test. The next test I'll be performing is the shoulder girdle passive elevation test. This is a relief test, so if a positive sign for this test would be if she had a relief from her symptoms. So in order to perform this test, she would need to be having her symptoms at the time the test was administered. So what I'm going to have her do is, can you hug yourself like this for me? Good. So she's going to hug herself. I'm coming from behind her, and I'm going to her elbows, and I'm kind of compressing her and then lifting her elbows up. Then I would hold this position for 30 seconds. And again, if she had any relief of her symptoms at all, then that would be a positive sign for this test. For neurologic involvement, if she went from numbness to paresthesia, that'd be a positive sign. And for any vascular, if instead of her not being able to feel her pulse, it became like stronger, then that would also be a positive sign for vascular involvement. Oh, what the heck? Next, I'll be testing my patient's reflexes. The first reflex that I'll be testing is for brachoradialis. And what I can do is I'm just going to have her hold her hand here. And to look for brachoradialis, I can have her resist me in flexion. So I see it popping up on the forearm. I find the tendon. And I can either use my reflex hammer and hit with my thumb, or I can go with the broad end of my reflex hammer and hit. And if I'm having trouble getting that reflex, then I can also have my patient close her eyes and look away. Sometimes clenching her jaw as well will help. So again, is that normally an easy one to get for you?
No.
Okay, good. Okay.
Yeah, it's hard.
So, yes, okay, and I can just mute that other stuff.
Mm-hmm.
All right. The next one that I'll be getting is biceps, which is testing for C6. So again, here I'm going to hold her forearm. I'll do it like this. And I can look for the bicep tendon by having her resist me in elbow flexion. So resist me. Good. So once I've found the bicep tendon, I can get my thumb there and hit. And And so same thing, I can have her close her eyes and look away, and also clench her jaw. And again, I can also look for, if I don't see an immediate reaction of her hand going up, then I can also look to see if I at least see her bicep contract, and that would still be the reflex working. For the last one, we'll be working on getting the tricep, which is C7. So here, I'm just gonna have her elbow up like this, and the same thing, I'm gonna stand back here just for the sake of the test, or for the video, but the same thing. So I could have her resist me in extension, so resist me. So now I'm on her tricep tendon. Are you okay here? Is this okay?
Yeah.
All right. And I'll have her look away. And again. And again, we're getting nothing. For the sake of the test, or for the video, I'm going to have my patient just closing her eyes while I perform this, because she thinks my face is funny. So I'm going to be testing cranial nerve 5, which is the trigeminal nerve, and I'm going to be performing the jaw jerk reflex. So I'm going to have my patient just open her mouth. I'm going to be placing my thumb on like the mandible, and I can kind of stretch the mandible as well so I can get a better reflex. Okay, and so I saw her close her mouth just a little bit, so that would be a sign for a normal test. If she were to shut her mouth completely really fast, that would be a sign of hyperreflexia. If she didn't open her, or she didn't close her mouth at all, then that would be a sign of hyporeflexia. Next, I'm going to be palpating for the lateral and medial pterygoid. I don't have gloves in this room, so I'm just going to be talking about how I would palpate for it. So for medial pterygoid, what I would do is I would place one finger on the inside of the patient's mouth, and I would place it at towards her bottom teeth, towards the back. Next, what I would have her do, if I was palpating on the left side, I'd have her move her jaw to the right, because I'm doing contralateral excursion. That should pop her muscle into my finger. If I were to do lateral pterygoid, I'd place my finger towards the top part of her teeth, towards the back, and I would place my finger, and then I would have her laterally excurse her mouth. If I was palpating for the left side, then I'd have her do it to the left side, because it does ipsilateral excursion. I could have her jut her lower jaw forward, so protrusion, to have that muscle pop into my finger as well. For masseter, you can either palpate it on the outside of the cheek or on the inside. If you wanted to feel for both, then I'd place my finger on the inside. The proximal attachment is in the zygomatic arch, and the distal attachment is towards the ramus of the mandible. So I would just place kind of in the middle there, and I would have the patient clench her jaw while I'm doing that, so I could feel the muscle again pop into my fingers. And I'm just looking for if it's if there's any mismatch in tone or hypertone or hypotone. For palpation of the temporalis muscle, temporalis, the origin point, is actually going to be located in the temporal fossa. The insertion point is going to be the coronoid process and ramus of the mandible. And it's actually going to insert on the inside of that place, so it's actually not, I can't palpate it on the inside, but what I can do is place my hands on her temple, and the temporalis muscle also helps with closing the mouth. So again, can you clench your jaw for me? And I should feel that move underneath my fingers, which I do. So next, I'm going to be educating my patient on the resting position of her tongue. I would use this if any of the muscles that I was feeling was in spasm and I wanted her to kind of relax those muscles, or practice any exercises with those muscles as well. So what I'm going to have my patient do is I can instruct her to think about when she says no, and kind of feel for the ridges of the top of her mouth, and just her tongue position when she says the word no. I can also have her click her tongue. So can you click your tongue? And then where her tongue is positioned there, that's the resting position of her tongue. She shouldn't be pushing her tongue up super forcefully up against the roof of your mouth. And sometimes when you're practicing breathing with the resting position, patients might want to like tense up their tongue. So making sure she's mindful of that. So this resting position also relaxes masseter and the lateral pterygoid. And while she has this position, she could be practicing any breathing exercises or opening and closing of the mouth while maintaining that position. While she's in this position, she should also have a little bit of space in between her upper and lower teeth. Can you open your mouth just a little bit? Just a little bit.
Sorry, I'm so sorry.
It's okay. Just relax. And just hang your mouth open.
Wait, I can't.
It's okay. You can't hang it open?
No, because you're making, when you look at me, I just get.
For palpation of the temporalis muscle.
Yeah.
Okay, and that should pop her muscle into my mouth.
You want me to pop the muscle in your mouth?
That should.
That's hilarious.
And then I'm just gonna hit my thumb. Did I hit your mouth?
Yeah.